Okay, today we'll be talking about myocardial ischemia and infarction. Okay, now what I've drawn here is a coronary artery in 4 different possible situations. Okay, this is normal, and this is what the EKG would be like over that area. For instance, let's say that this is a vessel which is supplying the inferior surface of the heart, bottom of the heart, and we're looking at lead 2, 3, or AVF. Let's say that this is lead 2. Okay, so the EKG over that area would be normal. Okay, now let's say that we have disease of that coronary artery, and we have a reduction in the size of the lumen. Now, what can we say about the status of the myocardium that's underneath that area? It's ischemic. Okay, and what does the EKG of ischemia look like? No, we see ST segment depression. ST segment depression. And is this situation reversible?
Yes.
Yes, certainly is reversible. For instance, if someone were to exercise, this is the basis for the master's test. You can bring out ischemia by exercise, and then it's reversible, and you can go back to a normal electrocardiogram. All right, now let's say that we completely occlude that vessel. What happens to the EKG in that situation? It's not infarcted yet. It will eventually, it becomes what? Injury. Okay. And with injury, what do you see in the electrocardiogram? ST segment becomes elevated. And is this situation reversible? Sometimes it is, right. Actually, in reality, it doesn't go back too often. Once you develop the pattern of injury, you generally go on to infarct rather than return to normal. However, it can return to normal. As a matter of fact, there's one type of angina that patients have where they develop this pattern in their EKG instead of ischemia, and then they'll return to normal. They develop this type of tracing during their episodes of angina. What type is that? Anybody heard of that? Right, this is the Prince metal variant angina. Prince metal. After the man who discovered the term, discovered the entity. All right, well, let's say if this injury has persisted a while, no blood has gotten through this vessel, then eventually the muscle will infarct, as everyone says. And what do you develop in the EKG that indicates an infarction? You develop a Q wave, right. So the tracing looks exactly the same, except now you have a significant Q wave. Okay, so that's the sequence of events. And is this reversible? No, once you reach that stage, it's not reversible. Okay, so this is the sequence of events then leading to an infarction. Okay, now let me ask you, what is a significant Q wave? How do we define a significant Q wave? Right, but there's criteria for its depth and its breadth. Right, greater than 1/3 the height of an R wave. Significant. This is a significant Q. Greater, some people say 1/4, but we'll say 1/3 the height of the R wave. And in terms of duration, how long? Greater than 0.04 seconds in duration. Okay. No, greater than 1/3 the height of the R wave. That means in terms of being deep. It has to be so deep that this depth is greater than 1/3 the total height of this R wave. Okay. Duration is indicated by terms of 0.04 seconds, one little block. Okay, so this is the sequence of events then leading to infarction. And what we're talking about right now, what they call transmural infarction. Okay, transmural infarction, there's one that goes all the way across the wall. This is the wall of the myocardium here. And transmural infarct goes all the way across. So this is the outside, and this is the inside. We can also have other types of infarctions. For instance, we can have subendocardial infarctions, or we can have intramural infarctions, which are located in the wall, inside the wall. And we'll be talking about non-transmural infarctions briefly just a little bit later. By far the most common types of infarcts are your transmural infarct, all the way across the wall. Infarcts with Qs, what I really mean. Well, let's go back here and we'll talk a little bit about ischemia. Okay. Cover each of these entities that we briefly passed over, go into them in more detail. Okay, first ischemia. Well, it's nice to think of ischemia really as being of two types. I like to think of it anyhow. One type called absolute, and the other type is relative. Okay, now by absolute I mean there is actual encroachment on the vessel wall, as you might have in coronary disease. This we would call absolute form of ischemia. Well, if that's what I mean by absolute, then what do you think we mean by relative? No. So in certain states, for instance, you can think of quite a few of these where you have a large load upon the heart. What types of situations will produce a load on the heart? Anemia, for instance, right? Large volume load. And there's lots of things that will give you a volume load. Shunts, hyperthyroidism, hypoxia. Many situations that we clinically encounter will produce ischemia in the electrocardiogram, as well as pressure overloads. The heart is really susceptible to pressure overloads. And things like aortic stenosis, hypertension will very readily wind up producing the ischemic pattern on the electrocardiogram. There does not necessarily have to be coronary disease. That's the point that I'm trying to make. It's just because you see ischemia on the electrocardiogram does not necessarily mean that patient has coronary disease. You just have an excessive workload. Or if you really are looking at gradations, you can have a very small amount of ischemia plus a large load on the heart. As a matter of fact, it's likely that if the vessel is completely normal, you can put tremendous workloads in the heart and you won't see ischemia. So, but if someone has small amounts of vessel disease plus a excessive load in the heart, then you may bring out ischemia and get the impression that there is more coronary disease than there actually is. All right? Everyone understand what I'm trying to get across here? All right, now, the electrocardiogram and ischemia. We have several kinds of changes. One type which I like to call the fairly specific changes. Fairly specific. And then we have non-specific. Okay, now the fairly specific, probably in its most subtle form, would look something like this. Can you see a change there from this pattern? There's a change. Okay, now let me just go on to the next. You can see what we're really getting at here. This is a little bit more severe. And then finally, frank depression. Okay, so you can see, if you look at this, how these are all just different degrees of the same sort of thing, right? This is what we call ST segment straightening. This is ST segment sagging. This is sagging. Okay, this is sagging. See the ST segment sagging down, and the ST segment finally depression. Okay. Now, in the beginning, before you have much practice in looking at this, you tend to first you tend to ignore all of these, and then you tend to overread them all, and finally, after a fair amount of practice, you eventually get to know really what is ischemia, what isn't. So what I'm trying to say really is that it takes a lot of practice and a lot of time looking at a lot of tracings in order to really interpret these things properly, prevent over and under interpretation. It's really the angle here that we're talking about. See the acuteness of this angle. Normally this angle is relatively obtuse. It's the angle between the ST segment and the T wave. And in ischemia, this becomes more acute. You see here how this is becoming more and more acute. Okay, now when we see these changes on the electrocardiogram, these are fairly specific, and we can say that these changes likely reflect ischemic heart disease. Of course, it doesn't tell you what type of ischemia we're dealing with, whether it be the absolute or the relative types we're talking about. But when you see these changes, they probably mean ischemia is taking place. On the other hand, these non-specific changes you just don't know. Now, here is an example of these. Okay, here the T wave is flat. Here the T wave is inverted, and here it's biphasic. When you see changes like that, all you can say is that it's an abnormal tracing and there's non-specific T-wave abnormalities. This may indeed reflect coronary disease. You just don't know. It may also reflect an electrolyte problem. It may reflect pulmonary problems, central nervous system problems, metabolic problems, or it may have some the patient may have a myocardial problem that has nothing to do with coronary disease. You just don't know. You have to call this non-specific. But the point is that this does not mean that this change is not due to coronary disease. In other words, this may very well be reflecting ischemia, but it may, on the other hand, not. You just don't know. All right, well, we've talked a little bit about ischemia now. Let's go on and talk about injury. We've already mentioned that this can reflect an acute infarction before a Q wave has actually develops, before actual muscle necrosis has taken place. Right? That's the classical situation where you develop injury on the electrocardiogram, right? Somebody who's going to go on to infarct. And the other situation that I mentioned is the Prince-Meadows angina. It's a variant form of angina. It's not too commonly seen. We see maybe 4 to 6 cases of this a year, Prince-Meadows variant angina. But it's nice to be able to know what it is and to recognize it for what it is rather than calling it part of an acute infarction. And it has clinical significance. Some people think that patients with Prince-Meadows variant angina have a single lesion in one of their major coronaries, and these patients are bypassable surgically.
How do you know when you get that?
Well, you record the EKG during an attack. He looks like he's about to infarct, has changes like this, and then you give nitroglycerin or tincture of time, and the attack goes away and he returns to normal. And sometimes people, there are many situations where you can gradually see this receding to normal, and then you can see it getting worse again. See it going back and forth, and this recurs time and time again. If somebody were going on to infarct, you'd see this appear, and they'd go on to infarct. It's very unlikely that he'd keep going back. Though it's possible, I suppose. All right, and what other situation might you see ST segment elevation in? There's one other situation where you get ST segment elevation. No, changes in potassium levels really don't change the ST segment. They alter the peaking of the T waves and do some other things. Well, what I'm saying is here's a patient, he's had an infarct, right? And he's a week after the infarct, it looks like this, and then you look again, send him out of the hospital after his appropriate rest period, and then he comes in 6 months later and he still has that. What do you think of? I mean, you don't think that he's had something active going on all that time. Oh, it's possible. Aneurysm, ventricular aneurysm. Okay, that's the third cause of ST segment elevation that you should keep in mind. Pathologic cause. By the way, there are people that go around with ST segment elevations who are normal, right? This is sometimes a normal feature for certain individuals. It's called early repolarization. You have usually slight ST segment elevation. Sometimes it's actually fairly significant. And this is particularly seen in blacks. ST segment elevations usually well seen in the left precordial leads. It's something to keep in mind so you don't say somebody has pericarditis or
What was the first cause of?
by the way, STC. The first cause is just developing infarct. In the injury pattern that one sees before an infarct actually develops. And by the way, in order to make our table complete, another pathologic situation where you see ST segment elevation is pericarditis. Should add. So there are quite a few causes of ST segment elevation. But remember also that it can be normal, frequently normal to see ST segments elevated. Not frequently, but not uncommonly. All right. Any questions now about ST segment elevation? Okay. If not, then we'll go on to talk about transmural infarctions. Okay. Now, if you're approaching an electrocardiogram, and it's going to be part of our routine to analyze electrocardiograms in a specific manner, going through with a certain routine. And one of the steps in our routine will be to ask ourselves, does this patient have an infarct? Okay, and the first question we're going to ask ourselves is, do we see Q waves in the frontal plane? Are there pathologic Q waves in any of the leads in the frontal plane? Now, it can be normal to have a Q wave in AVR, right? But any other leads, you should not see pathologic Q waves. Okay. If we don't see any there, then we go to the horizontal plane and we look at the R wave progression. Is the R wave progression normal? If the R wave progression is normal, there's no pathologic Q waves, we can say then that there's no evidence for transmural infarction. And we can go on to the next step. Right? So, is there an infarct? Q waves in the frontal plane, and then R wave progression in the horizontal plane. Okay. If we do see signs of an infarct, then we want to ask ourselves two questions. What are they? No. What do you want to know about it?
Where is it? How long has it been going on?
Right. Where is it located? What surface is it located? And how old is it? Okay, and that's what we're going to talk about now. Okay. Okay, first we'll talk about evolution. In other words, dating of the infarct. And what we're going to try to do is to localize our infarct within 3 periods of time, whether it's acute, recent, or old. Okay? Well, let's just say that this is what the acute infarction looks like. And let's just draw on the board here the sequence of changes that takes place as time goes along. First thing that'll happen is your T wave will start to invert as your ST segment is coming down. Finally, your ST segment will be down. Your T wave will be deeply and symmetrically inverted. These are called PAR-D T waves. These deeply symmetrically inverted T waves, PAR-D. I think it's spelled with 2 E's. PAR-D T waves. And then as further evolution takes place, this T wave will be less deep, gradually come up, and eventually this T wave will become upright. Let me ask you now, what do you consider to be an acute infarction? What's the sign of the acute infarct? Right. ST segment elevation is the sign of the acute infarct. So ST segment is a sign of acute infarction. Okay, what's the sign of a recent infarction? The ST segment is returned to baseline, and then what happens? Okay, but when do you reach the end of that period? How do you know that you're out of that period? No, that's the end of the acute period when the ST segment reaches the isoelectric line. Yeah, but the end of that period is marked by the return of T waves to being upright. So the recent phase is marked by T waves, T wave abnormalities, T wave inversions, right? And then in the old infarcts, what do you say? Q waves, right? You may see only a Q wave, and eventually those Q waves may disappear. They don't disappear in every case. As a matter of fact, I suspect they don't disappear in most cases. All right, now, generally, how long does one stay in this acute phase? Is it a matter of weeks or months or years, or how long do they stay? Days. A matter of days. It's an average of about 3 to 5 days. And this ST segment generally then takes an average of 3 to 5 days to come down. Bear in mind, however, that there's a marked variation. Some people, when they come into the hospital, they've already evolved to this stage. Other persons, they'll be in the unit for several weeks, and they'll still have ST segment elevations. So this is I'm just trying to give you a rough range, so you have some numbers you can hang your hat on. Okay, so the ST segment generally stays elevated 3 to 5 days, and you'll notice also that this coincides fairly well with the time that we usually keep patients in the intensive care unit. Because it seems that when their ST segments are elevated, it seems that this seems to be associated with electrical instability, arrhythmias, things like that. Right? And therefore, if we see a patient, we generally keep a patient in the unit for 4 to 5 days. But if his ST segment remains elevated, we may watch him a few more days. Right? All right. So, following the acute phase, in other words, beginning at roughly a week or 3 to 5 days, when the ST segment has returned to baseline, the T waves become deeply symmetrically inverted. This is when we begin our recent period. And how long, as an average, does this recent period last? How long do these T waves stay inverted is what I'm trying to ask you. Months, right. It does stay months. Average of 4 to 6 months. But again, this is just a very rough estimate because there are people who will be upright again in 6 weeks, and there's others who, in the course of the rest of their lifetime, their T waves will never come up. Right? So this is just an average. But this can be very important, for instance, if you're on medicine and they're asking you to, if you're anesthesiology, you're going to evaluate someone for surgery tomorrow, and you see his electrocardiogram, and you see some changes that look like this, and that have been overlooked. And you ask the patient, have you ever had a heart attack? The patient says, no, never had a heart attack. And then if you probe a little more deeply, you may find, for instance, they've had an episode of very severe indigestion a couple of months ago, but they just went and lay down that night and felt a little weak the next couple of days, and then they went back to work. And that may have been an infarct. And of course, you don't like to operate on someone who's had an infarct with recent past. Increased surgical risk. So that's the potential importance of recognizing the age of the infarct. All right, then after your recent period, then you develop these Q waves, and these, as I said, these Q waves may persist for years. In some cases, they disappear. Well, in terms of the enzyme changes all take place during the acute phase. You know, the first enzyme to change, and one that changes most rapidly, is the CPK, then the SGOT, which is within several days, and then the LDH, which has a more gradual curve. But the latter part of the SGOT and perhaps the LDH will overlap into the early recent period, but generally these changes are all really during the acute period. In terms of let's talk a little bit about localization of the infarcts. Okay, what are the different surfaces that you might see an infarct on? Okay, we can say the inferior, the anterior, and the posterior. Okay, these are really the three basic surfaces, right? And we can divide our anterior wall into several areas, right? But how would you like to divide the anterior wall if you had your choice? Yeah, all right. Well, we have anteroseptal, we have direct anterior, then we have anterolateral, and then finally we have what they call high lateral. Anteroseptal being located really in the front here over leads V1 through V3, and as you go around more towards V5, V6, right? And we'll go into that in a little more detail. Well, let's just take inferior infarction first, right? Which lead would you expect to see the changes that we've talked about, all these changes in an inferior wall infarction? Lead 2, 3, and AVF, right. This is something you should start to be thinking about, is grouping your leads together. You shouldn't go through a tracing and just describe isolated events taking place, T waves in this lead and Q waves in that lead. You should be thinking of your leads in terms of groups. So inferior surface, you should think of right away, 2, 3, AVF, right? 2, 3, AVF. Okay, so going back, if we see ischemia on the inferior surface, right, we'll see the changes that we talked about with ischemia and all the variations thereof taking place in these leads, 2, 3, and AVF, right? If we see injury in the inferior surface, we'll see ST segment elevations in leads 2, 3, and AVF. We'll see it in the appropriate surface, right? All right, now, talking about the anterior wall. Now, if you recall, we made a diagram a while ago in our first lecture here. It looks something like this. And we talked about R wave height. And we plotted that against the lead, V1 through V6. And we said that you get a normal R wave progression that looks something like this. Right? As you go around over towards V6, perhaps I should draw this. The peak of the R wave is generally around V4. Okay, so this would be a normal R wave progression. And as I said, we want to look at the R wave progression when we're trying to diagnose infarction. Okay, now with an anteroseptal MI, you get an abnormality to the R wave progression. Right? You can see a loss of R waves in leads V1, maybe through V2 and V3, and then after that your R waves would become normal again. All right, so that would be an anteroseptal MI. Let me erase this here. Maybe I can illustrate this a little bit better. Okay, this is V1, V2, V3, V4, little q, V5, V6, something like that. Okay, that's a normal R wave progression, as I indicated, right? The R wave is gradually getting bigger around out to V4 and then decreasing again. Everyone recall that? Normal R wave progression. And as I said, when you have an anteroseptal wall MI, you lose your R waves in V1 and V2, let's say. So you just have Q waves there. It's a loss of the normal R wave progression. And if we were to plot it, what we get is a graph that looked like this. Right? No R waves around out till you got to V2, and then normal R wave progression after that. And this is the normal R wave progression here. Okay, so in an anteroseptal MI, you see your changes in which leads? Yeah, V1 through V3. Okay, now direct anterior wall MI. You see normal R wave progression proceeding out maybe to around V2 or V3. You have a loss of the R wave progression, and then a return to normal R-wave progression. And if we were to take a look at our electrocardiogram, we'd see normal R-wave progression out to V2. About this point, we may see a loss of the R-wave. We may not see a Q-wave develop yet. In this lead, though, we may have a Q. Initial Q. So you can see the R-wave is progressing normally up to a point. Then you have a loss of R-wave, and then a return, just as in this diagram here. Right? So we see our changes then in which leads for direct anterior wall infarction. Right, V maybe 3 through, or V2 through V4. Lead V2 through V4, we might see these changes. And then with a lateral wall infarction, just carrying this out, I don't think I have to re-diagram this entirely. You'll develop deep Qs laterally. You lose your normal R-wave progression out in V5 and V6. So anterolateral will be V5 and V6. Okay. Now, when you're looking at an inferior wall infarction, right, you see your changes in the leads down here. When you're looking at anterior wall infarction, you see the changes across the anterior wall. Now, what leads in the frontal plane might you also see changes in, what leads in the frontal plane, right, what abnormalities in the frontal plane might reflect horizontal plane abnormalities as well? In other words, which lead is pointing in this direction, out in the direction of E6? Lead 1 and AVL, right? So very frequently, in patients who have anterior wall infarcts, we also see changes in leads 1 and AVL, right? We see changes in leads 1 and AVL as well. And there is a certain type of infarct where we just see changes in lead 1 and AVL, and we do not see any changes in the anterior wall at all of the type that we've described. And these are called by some people high lateral infarctions. They're way around in the back here, high lateral wall infarctions. So we get our changes maybe just in 1 and AVL. In these other leads, anteroseptal, direct anterior, anterolateral, we very frequently see also changes in 1 and AVL. But if we just see changes in 1 and AVL and not in the precordial leads, we might make a diagnosis of a high lateral wall infarction. All right, now, maybe we should just stop here for a minute and stand back and say, well, so you have an infarct in 2, 3, and AVF. What vessel is involved? What coronary vessel, what coronary artery is involved? Right, these are lesions of the right coronary. The right coronary, in most individuals, supplies the inferior surface of the heart in 90%, 85 to 90%. Okay. Whereas the anterior wall, for the most part, is supplied by the left coronary. Right, right. And this would be, this area here would be the area supplied by the anterior descending, V1 through V3. This is the region supplied by the LAD, the anteroseptal region. And these might be some diagonals. And as you come around here, you get to the marginals, the marginal branches of the circumflex, as the circumflex is taken off. And over here, this is going around to the posterior circumflexes. The circumflex comes around behind the heart. See, both vessels go around and meet behind the heart. So the posterior wall of the heart may be supplied by either the right or the left coronary. Now in man, well, whichever vessel supplies the posterior wall of the heart, that vessel is called the dominant vessel. And in man, the right coronary is usually dominant. In other words, the posterior wall of the heart in man is supplied by the right coronary in 90% of cases, 85% of cases. 10% by the left, by the circumflex as it comes around, and about 5% of cases by both. Okay, whether in that situation it's called a balanced circulation. 85% the right, 10% the left, and 5% a balanced circulation. They call it balanced circulation. And this assumes some clinical importance, right? Because what structure comes off the vessel which supplies the back of the heart? The vessel which goes to what structure? Well, to the AV node, right. The artery to the AV node comes off the vessel which goes to the back of the heart, comes off the crus, right? And what kind of disturbances do you see when the AV node is involved? Yeah, heart block, AV block, right? And that's the reason why you see AV block so frequently in patients with inferior MIs, because in most individuals, the right coronary supplies the inferior surface, the posterior surface of the heart. All right. Okay, now let's localize one final area here. Most of your infarcts, by the way, your transmural infarcts, are either on the inferior or the anterior surface. I'd say that covers, or the transmural probably covers over 90%. Rarely you'll find someone that has what they call a true posterior or direct posterior wall infarction. But it's worthwhile recognizing this entity when it does occur. Let's say, for instance, that you're looking at the vector system in the frontal plane, right? And this is lead 2 going down this way. And lead 2 looks like this. Let's say you have an infarct pattern in lead 2. Looks like that. What would you expect to see in AVR coming up this way, approximately in that direction? Right, you get mirror image change, what they call reciprocal changes, okay? If you turn that upside down, you get something that looks like that, right? Mirror image change. Okay, this is the principle then for the diagnosis of direct posterior wall infarction. Okay, we look for mirror image changes when we're diagnosing posterior infarctions. So we said V1 normally looks like this, right? V2, V3. Now, someone that's developing a direct posterior will get a tall R wave and depressed ST segment. And you may say, well, that looks kind of strange. It looks a little bit like inferior, it looks a little bit like anterior wall ischemia, anteroseptal ischemia, but it really doesn't look kind of strange, right? Now, but if you were to turn this upside down in your mind, you'd recognize it for what it was, really, right? And think of it as a reciprocal change. So we'll do that. We'll just turn that upside down, and everybody recognizes that old friend, right? That's infarct, right? So what we're doing is looking at mirror image changes. Okay, so this is what happens with the acute infarct then. As this evolves, you'll still see your tall R wave. Your ST segment will return to baseline, and you'll get your PAR-D T waves. Okay, and as this evolves further in time, this T wave may not look as prominent at all, and then you have a problem. How do you differentiate this from right ventricular hypertrophy? And it can be a problem electrocardiographically, and vectors will help you make a definitive diagnosis, though. Differentiating an old true posterior infarct from right ventricular hypertrophy. But if you see the acute situation and you see the evolution, there should be no question. Okay, now if we were to plot this in terms of our diagram, one that we drew before, right, normal R wave progression, okay, what we'd see with a direct posterior is you get tall R waves in the right precordial leads, and then the rest of the R wave progression would be fairly normal. Okay, tall R waves in the right precordial leads is the sign of direct posterior wall infarction. And then if it's acute, of course, you get your ST T wave changes. Okay, are there any questions about that?
Would there be any advantages in using, say, a V10, 11, 12 all the way around the back to get that?
Actually, there probably would be. They say that that loops reflecting right ventricular hypertrophy have a certain clockwise, actually have a clockwise rotation, whereas loops with a direct posterior wall infarction, even though the loops look the same, will have a different orientation. So if you can get your transition zone and actually plot out the loop, and this is a project that we're thinking about doing right now, you may actually be able to diagnose it electrocardiographically. Certainly, it's easy to diagnose clinically, right? if you're trying to differentiate whether someone has right ventricular hypertrophy or direct posterior, all you have to do is put your hand on the patient's chest, right? If he has enough right ventricular hypertrophy to give you this kind of a change in the EKG, you'll feel a left parasternal lift, right? So it may be a problem to diagnose electrocardiographically, but certainly should be none clinically using other methods you have available. All right. So that's the story then on transmural infarctions. Now let's talk, unless somebody has some questions about what we've covered, let's talk very briefly then about non-transmural infarctions, the subendocardial and the intramural infarctions. Now let me just say that the EKG is very good, is certainly satisfactory, or a good tool in diagnosing transmural infarctions. It is not anywhere near as satisfactory for diagnosing non-transmural infarctions. The criteria for diagnosing your EKG are: 1, clinical history, right? The patient's had crushing chest pain, etc., the general story. Okay, a second criteria is your enzymes, and your third criteria is your EKG. Okay, in your transmural infarctions, you can rely heavily on the EKG to make the diagnosis. In your non-transmural infarctions, you have to rely more heavily on these other two, right? Unfortunately, that's the way it is. This EKG does not help you as nicely as it does with the transmural infarction. Okay, but this is the typical change that you get with an acute intramural infarction. You get no Q waves, and you get your PAR-D T waves. They may be located on the inferior surface. More commonly, they seem to be located on the anterior surface. So if a patient comes in with a classical history of terrible chest pain, he has a typical enzyme rise, and you see this change here on the electrocardiogram, and this change has to persist. It can't be here today and gone tomorrow. That change has to be there for weeks. It should be there for weeks in order for you to have EKG confirmation of this diagnosis. Okay, this is what you see. You get these deeply symmetrically inverted PAR-D type T waves. Okay, so that's your intramural. Now, in the subendocardial infarct, your diagnosis is even poorer as far as I'm concerned. Again, you should have your other criteria. And the EKG change that you get in this situation looks a little bit like digitalis effect. You have sort of a deep, kind of a coved ST segment. And again, this change has to persist for weeks. It can't be just a transient phenomena. And it's usually seen in leads which overlie the left ventricle, because it seems as if that's the area which is most deprived when the heart really needs a good blood supply. Now, if the patient's on digitalis and you've never seen an EKG on him before, this diagnosis is very much in question from an electrocardiographic standpoint. Right? You just don't know. However, if the patient's been on digitalis before and has had a different pattern, and then has changed to this pattern, right, then you feel a little bit more confident about the diagnosis. But the point that I'm really trying to make is that the major point is that in intramural and subendocardial MIs, your EKG is not as good, and you have to rely on all the criteria you have available. Okay, by the way, everyone knows I meant to cover this when I was talking about ST segment changes, and everybody's familiar with this pattern, right? Digitalis, right? This ST segment is scooped. Some people call it scooping, hammocking, coving, and an easy way to remember is that the pill of digitalis fits into the ST segment. All right. Well, today we talked about ischemia and infarction. You know what ischemia looks like. You have an approach to what ischemia looks like in an electrocardiogram. When you're approaching to a diagnosis of question infarct, as I say, we're going to go through our routine. We're going to say, does this patient have an infarct? We're going to look for Q waves in the frontal plane, right? R wave progression in the horizontal plane. If we see no signs of an EKG, go on to the next step. If no signs of an infarct, we go on to the next step. If we do see signs of an infarct, we're going to go back, we're going to say, how old is it? Acute, recent, and old are the criteria that we've just talked about. And where is it located? Right? Simple as that. Okay, are there any other questions?